Hello and welcome to today's webinar, Navigating Scaling and Route Planning Claim Submissions. This is part of a series of tutorials on dental benefits brought to you by the ADA's Center for Dental Benefits, Coding, and Quality. My name is Dennis McHugh, and I'm the ADA's Senior Manager for Third-Party Payer Issues, and I work in Practice Institute's Center for Dental Benefits, Coding, and Quality. I've been with the ADA for 23 years, and prior to that, spent 7 years working with the American Association of Orthodontists in a similar role. Please note that this presentation provides general information and is not a substitute for legal advice. Dentists should contact their own personal attorney for specific legal advice. And now I would like to introduce our first presenter. Dr. Mark M. Johnston grew up in a small town in mid-Michigan and knew at a very young age that dentistry was the career that would be the most fulfilling for him. After attending college in New Hampshire at Dartmouth, he returned to Michigan to attend dental school at the University of Michigan. During his 38-year career, he has been involved with organized dentistry since day one. He is a past president of the Michigan Dental Association. Currently, he is the president of the for-profit subsidiary of the Michigan Dental Association and also a member of the Michigan Board of Dentistry. In addition, he is the chair of the ADA Council on Dental Benefit Programs, Dental Benefit.
Let's begin. Dental enrollment. Why is this information important to you? According to the National Association of Dental Plans, abbreviated NADP, almost 280 million people had a commercial or publicly funded dental program in 2021. In 9 years, dental plan enrollment has increased by 67%. That's 84% of the US population with some type of dental benefit. Next slide, please. As far as types of dental plans are concerned, if you look at the brown column on the far right, you can see that 88% of commercial dental plans are preferred provider organization plans, PPO plans, which dominate the marketplace, and PPOs have grown by 10% since 2012. Right below that, you can see that dental health management organizations, DHMOs, represent only 4% of the market. Indemnity plans, which were dominant in the 1970s, now cover less than 3% of the market. Let's not forget discount dental plans, also known as referral plans. These plans are not insurance and do not require that a claim form be sent to a payer. A network dentist has simply agreed to a discounted fee, which the patient pays directly to the dentist. Discount dental plans account for 5% of the dental benefits market and are typically purchased on an individual basis. However, some employers are starting to offer discount plans as their employee dental benefit program. Dennis, next slide, please. This chart indicates the number of individuals covered by fully insured plans compared to the number covered by self-funded plans. In 2021, fully insured plans covered 54% of those with a dental benefit, while 46% were covered by self-funded plans. So why is this important to you? Fully insured plans are typically governed by state insurance statutes. Unfortunately, self-funded plans often take the position that they are established under a federal statute known as ERISA and are exempt from state insurance laws. Rarely do you see this information on a dental insurance card, if they have a card at all. Usually, a designated person at the dental office is in charge of investigating the type of plan the patient has. Thus, this is definitely something to be aware of when patients present with these types of plans. Next slide, please. A common question ADA staff receives is how many dentists participate in PPO plans? As of 2022, over 217,000 dentists participated in at least one PPO plan. And you can see in the top chart that just over 30,000 dentists participate in one plan, while almost 65,000 dentists participate with 26 to 40 plans. And if you look at the lower chart, dentists are listed in an average of 26.6 networks. This can occur because Plan A may have 3 different networks that they use for different employer groups. And while you signed up for only one, you could be listed in all 3 of Plan A's networks. So the actual number of contracts you have signed will likely be lower than the number of networks you are listed in. And if you contract with a PPO leasing company whose network is utilized by dental plans across the country, you could be listed in multiple networks as well.
Thank you, and good morning, good afternoon, depending where you are. In presenting the payer's perspective, the content that I'll be sharing, we can go to the next slide, it's my own impressions and experience that I have in the industry, not being representative of any company, any association, any group, or any society. And I'm presenting the information here as informational content, not intended to set any policy, not intending to set any standards of care. Again, these are my own opinions that I want to share with you today. We can go to the next slide. What I'm showing here is a key to the way we all kind of go through life. Having an established process, in our case, in a submission process, having an established routine process for submitting claims, or whether it be for root planing and scaling or any other procedure, will increase the efficiency and the accuracy of those claim submissions. Like anything else, we all start at the basics, like building blocks. We start with the current ADA claim form. Then we move to selecting the proper and appropriate CDT code to report, and combine that with supporting diagnostics and documentation. Next slide, please. In requesting benefits to a third-party payer, the section of the ADA claim form where this is provided service or proposed service is recorded and communicated is the center of the claim form. Now, yes, the ADA claim form has sections above and below this center part for payer information, subscriber information, payment information. I'm not going to talk about that. I want to talk about the area where we record the services provided. The date, the area of the oral cavity, tooth number, tooth numbers, procedure codes, etc., is all captured here. And so in the area where we record the services to be provided, in the center of the section, ironically, in the center of this discussion, will be where you report the procedure code. Next slide, please. Thank you. So it's box 29, the procedure code. This is where the code is reported. The dentist's clinical decisions determine what service and therefore what is the appropriate code to report after considering the CDT manual. Careful reading of the code will allow the dentist to accurately report the proper procedure code for the service that was either proposed or performed. Codes should not be chosen on the sole basis of benefit plan reimbursement. As the ADA repeatedly tells us, report what you do and do what you report. Next slide, please. The ADA has many resources to help with coding and coding selection. A very useful tool to determine the appropriate coding for several periodontal procedures is the decision tree that's provided in the Guide to Reporting Code D4346, Scaling in the Presence of Inflammation. This decision tree helps us visualize as well as guide us in determining the proper CDT code to report for not only scaling and root planing, but other related periodontal procedures. Next slide, please. In selecting the proper procedure code to report, D4341, periodontal scaling and root planing, 4 or more teeth per quadrant, this would look like when you're reporting that service, the date, the oral, the area of the oral cavity, in this case 20, the upper left quadrant, and the procedure code D4341 and the descriptor. Next slide, next advance. Combined and associated with code 4341 is the 4342 code, which is periodontal scaling and root planing. It's 1 to 3 teeth per quadrant. In this case here, you see we have a submission showing the date and the area, but not the tooth number for procedure code 4342. This submission would likely be returned to the dental office asking for the tooth number or teeth numbers in the area to identify to keep the patient's electronic health record accurate by the third-party payer. It's called the tooth chart. Below that is an appropriate submission for D4342, 1 to 3 teeth, where teeth numbers 2, 3, and 4 are identified. Next slide, please. We want to obtain the proper documentation and diagnostics to be submitted with the claim. Third-party payers are not there with the dentist. They're not in the office. We're not in the member's lap. We're not standing over the provider's shoulder. So we need some information to help us appropriately determine the adjudication of that claim not being there. So we would ask for full periodontal charting. It's the pocket depths. They need to be recent, usually less than 6 months old, showing more than just the pocket depths, the level of attached gingiva, whether you're reporting it in millimeters or not. Is there a furcation involvement? Is there mobility, bleeding upon probing? These are the normal types of diagnostic information you would have on a complete periodontal chart anyway in your office. Then backed up with periapical radiographs. They're preferred over bite wings, should be less than 1 year old. I'll talk a little bit more radiographs in a moment. And if you have a patient who has been in active periodontal maintenance schedule, then previous as well as recent periodontal charting will demonstrate the changes. It will tell your story. It will view the pocket depths between appointments, which will be very helpful to the third-party payer. Next slide, please. When we are talking about periodontal charting, again, they need to be complete. Some plans define it as within 12 months, within 1 year, no more than 12 months, while others do not. Periodontal charting does demonstrate the loss of clinical attachment or bone loss, recording the pocket depths. Some plans require 6 points per tooth, while other plans do not. And as I mentioned, we want to know other factors, furcation defects, bleeding upon probing, mobility. Next slide, please. The benefits are extended per plan and payer guidelines, processing, and clinical policies. Individual plan guidelines are very similar between plans, but they're not the same. So here's some examples that I have. I've identified them as plans A, B, C, D, and E. I've obviously de-identified the plan name. Information that was readily available through the plan's website, that's public knowledge. Plan A requires 4 more teeth with 4 millimeters or 5/32 of an inch more in quadrant, showing evidence of bone loss. Plan B is identifying their requirements as 4 to 6 millimeters with radiographic evidence. Plan C requires root surface calculus, radiographic bone loss, other areas they want reported, and 5 to 8 millimeters. Plan D, on the other hand, they are talking about full mouth pocket charting at least 4 millimeters, and also the presence of interproximal calculus, where Plan E, they want you to type it case type 2. Now we know the American Association of Periodontics has a different rating and staging system, yet this plan is asking for case type 2. Again, they're similar but not the same. Next slide, please. In providing periodontal charting, whatever works for your office. No one is being prescriptive. On the very far left image, we show a computer software program, and you can see the periodontal probings. The red colors are bleeding on probing indicators. There's a legend there I didn't capture for our presentation today. The image on the far right is another computer program that software is capturing the periodontal probings, as well as topographically indicating where the attachment is. And in the center is a handwritten periodontal charting. You can read the numbers. You can see that certain numbers are circled in red, which I would assume means bleeding on probing. There should be a legend there, but my examples show you it doesn't matter if it is computer generated, software generated, or handwritten, as long as we can read the numbers. That'll help the diagnostic value being legible for the third-party payer. Next slide, please. On the other hand, unfortunately, we do see some submissions that look like this, and these are actual submissions that I have captured. The one on the left, you probably have a difficult time, as I did, determining some of those numbers. Are those 3s? Are those 7s? Is there a 4 there? It's a little bit difficult to determine what is going on in this patient's mouth. The image on the far right there is even a little more difficult, where being presented to a third-party payer, we would really struggle to try to determine the exact pocket depth that is being reported to us. Next slide, please. Should you have a third-party payer that accepts facsimiles, I want to caution you against using textured or colorized paper. This is what comes over on a fax. So it may look clear in your hand when you're faxing it to us. However, when it's received and generated and reproduced by the fax machines, this is what it comes out in. And again, this is going to delay the claim. This might even have the claim returned for clarification. So the legible periodontal charting is key. Next slide, please. As well as identification of the teeth. So here we have an example of the D4342 partial 1 to 3 teeth per quadrant. The image on the left, that's pretty indicative of what this would look like, right? We have teeth number 22, 23, and 24 are being reported. There are no other missing teeth in the quadrant. This would satisfy 1 to 3 missing teeth. The image on the right would be a little more difficult. Does this plan require 4 millimeters of attachment reported loss, or is it 5 millimeters? And if so, which teeth are being treated, again, to help that patient's tooth chart? So we want to be clear when we're submitting our claims to have the proper identification of the code and the identification of the teeth on the charting. Next slide, please. So I'm going to go back to radiographic images for a moment. So the diagnostic quality needs to depict the appropriate structure, preferably bite wings, as long as the image captures the bone height in relation to the root and any furcation. Sometimes the full mouth series are submitted. Should be properly mounted, labeled with the date of acquisition, the patient's name, and the right or left orientation. We do receive images where sometimes there's a struggle. Is it the right side or the left side on the right or left side of the image that's being presented? Again, individual plan guidelines are similar between plans, but are not all the same. In the 5 plans I'm showing here, and these are not the same A, B, C, and D as I previously mixed them up on us, just to keep the identity secret. Plan A is asking for current submitted labeled preoperative x-rays that show the treated teeth, where Plan B, a simple statement, full mouth radiographic or digital images. Plan C is a little more specific. Dated preoperative radiographs, diagnostic quality, depicting the appropriate structures, labeled left and right. They're saying that the radiograph should be duplicated, less than 36 months old, and labeled with the patient's name. This plan wants the provider's name and address. Plan D is asking for a full mouth set of bite wings, clearly shows the appreciable bone loss. Plan D, on the other hand, in their guidelines was completely silent on radiographic images. Next slide, please. I don't need to show much more of what a quality survey would look like. You all are experienced and are well versed in that area. Next slide, please. The benefits sometimes are not extended per the individual payer plan guidelines. There are coverage limitations. They vary by the benefit plan selected by those clients. There's eligibility. Maybe there's a waiting period. There's frequency, plan limitations. Here, plan X, Y, and Z, the scaling is limited root planing to 1 time per quadrant per consecutive 24 months, whereas plan W, it's limited to 1 every 12 consecutive months. Similar, but however, not the same. Next slide, please. Plans may not extend benefits for plan provisions, as I had mentioned. Some plans may require documentation of the use of local anesthetic. Plan A, their guidelines require periodontal scaling and root planing and the administration of local anesthesia by intramucosal injection. Pretty specific. Plan B just says routinely requires local anesthetic. When it comes to 4 quadrants of root planing and scaling in one appointment or one visit, we have to have a little discussion. We know that scaling and root planing is an arduous, time-consuming technique and service procedure that we provide for our patients. It's difficult at times for the patient and for the operator, for the dentist or the dental hygienist. It can be a little difficult, 4 quads in one visit. Keeping that in mind, some plans, policies may not extend benefits for more than 2 quadrants in one visit, regardless of the documentation. It could be a contractual provision. Where some plans, they may have an extra layer of utilization review criteria when more than 2 quadrants are reported in one visit. And that supportive documentation would include the treatment record, the amount of time that you provided the treatment for that patient, the local anesthetic that was used, or any other situation that would tell the story, if you will. Medications, long travel time to the office, blood thinners. There are a lot of reasons that would support 4 quadrants of root planing and scaling on the same visit. Next slide, please. Here's an example of some of that documentation. This is an example I pulled from earlier this year. That was the entire treatment note. Now, I'm not going to talk about medical legal record keeping. The ADA has a great resource on documentation of the patient record, but here they can read 4 quadrants, scaling and root planing. I'm not sure what the squiggle means after that. I'm assuming it says chlorhexidine medication, postoperative instructions. It really doesn't tell the story, if you will, a little bit thin. Can we advance to the next section? Here's another notation that's far more complete. Again, I'm not being prescriptive of what you may or may not include in your notes. You're the best to be the best judge of that. But this particular example is showing the SOAP format. The SOAP format, for those of us who are not familiar with it, talks about the subjective, objective, assessment, and plan. It's an organized way of making your notes. Again, we're not saying they have to be this way. I'm giving you an example. Some might argue this is too much information. Again, this is an example. Next slide, please. A lot of our software programs have templated notes. Templated notes or computer-generated notes is a great tool for time saving, efficiency, and consistency in recording our notes. However, the key point here, they need to be individualized. That they're good format, but you can add to them and individualize them for the patient. Yes, this is an example of a prophylaxis, not root planing and scaling, but my point is there's nothing wrong with a templated note as long as you individualize it for the presenting patient's conditions. Thank you so much. I'm going to turn it back over either to Dennis or CJ for our next speaker.
Hi, thank you, Stuart, for that information from the payer side. We appreciate it. So our next presenter is Dr. Jessica Stilling-Mala, who is a board-certified periodontist practicing in the Tampa Bay area since 2008. She received her bachelor's in dental degrees from the University of Florida and her periodontal training from the Ohio State University. She has been a member of the Council on Dental Benefit Program since 2019 and currently serves as the council's chair. Now we will hear from Jessica.
Thanks so much, Dennis. I'm glad we got your mic working. Hello, everyone. As we've heard from the payer side, scaling and root planing can be, unfortunately, one of the more frequently denied claims. When we asked some of our carriers at the council level why, their response was there were issues with not only documentation, but diagnosis. The bigger issue for us as providers is even though D4341 and D4342 are not by report codes, you still have to send supporting documents to show the carrier how you got to prescribing root planing. This can be confusing, and staff may not always understand what appears to be inconsistent root planing claim adjudication. Dr. Balikoff mentioned some of the variations in the various payers' payment parameters. This can be very frustrating for dental offices, as each insurance company has a different policy regarding adjudication of scaling and root planing claims. The problem for the dentist here is that the denial EOB language may lead the patient to think that the procedure is not medically necessary. Denial does not mean that the root planing was unnecessary. It may mean that the patient's clinical condition does not satisfy the benefit plan's threshold for reimbursement. It is appropriate to appeal the benefit decision if you think the claim has not been properly adjudicated. Also, you may want to recommend that the patient talk to his or her human resources department about the level of coverage provided by the plan. Remember, it is the patient's plan, so they can share some of the responsibility in terms of getting proper adjudication. Next slide, please. So I do want to address the point about proper periodontal diagnosis. In 2017, the American Academy of Periodontology did change the way that we were used to diagnosing periodontal disease. And although that's a whole webinar all by itself, I don't want to get into that, but I do want to highlight that your diagnosis comes from your clinical attachment level, not your pocket depth. What you see here is an example of periodontal charting. Everyone's charting will look different depending on the software you use or if you're using paper charting. I do want to draw your attention to the probe depths and the margin position. Remember, clinical attachment level is a calculation of pocket depth and margin position. Most software will automatically calculate your clinical attachment level. If you do not record a margin position, the computer thinks that you are at a level of 0 and your pocket depth will be equal to your clinical attachment level. If you have recession, that will add to your pocket depths, and the result is a greater clinical attachment level. If the tissues are inflamed and hyperplastic, your margin position is subtracted from your pocket depth, which will reduce your clinical attachment level. The clinical presentation of someone presenting in this manner will have deep pockets, but little to no bone loss on radiographs. For some carriers, this will be an automatic adjudication of a denial. Next slide. For some of you, this might be bringing back nightmares from dental school years, and I do apologize for that, but I know that visuals help understand, so this is why this is here. The picture on the right of the screen, you can root plane all day long, and you should get plenty of coverage. There's bone loss and calculus here. On the other side, however, you can have excess tissue, which makes you think you have a true pocket, but in reality, it's what we call a pseudopocket, and root planing is in fact not indicated. For those patients with pseudopockets, you should be looking at coding D43, 46, which is scaling in the presence of gingival inflammation. So I do want to take you through some of the examples of patients who needed 4 quadrants of scaling and root planing. Let's move on to the next slide. This is a charting from a patient from my personal practice. She presented to have her periodontal disease treated prior to restorative dentistry. You can see here how we have charted pocket depths, mobility, and bleeding points. No recession was noted at this exam, and so the cal is equivalent to the probe depths. If you just look at this charting, you get a sense that you should be seeing bone loss on her radiographs. So let's now take a look at those x-rays. Here you can absolutely appreciate both horizontal and vertical defects, as well as radiographic calculus. The diagnosis for this patient is generalized stage 3, grade B, periodontitis, and the carrier had enough information to pay this claim for the patient. Next slide. Here we see a charting from another patient in our practice. He is a patient that has had a history of osseous surgery in 2008 and has been on 3-month periodontal maintenance since that time. You can see here he is presenting with deeper probe depths in the posterior areas with bleeding on probing. Is this a case for root planing? Let's go ahead and see the radiographs for this patient. Although this one is a bit trickier, you want to go ahead and use your posterior CEJs on your bite wings to see the horizontal bone loss. Luckily, this patient has not had a change in dental plan since 2008, and we were able to provide records to support his history of surgery, as well as 3-month periodontal maintenance. This was also a case that was adjudicated for 4 quadrants of root planing, as we had exceeded the frequency limitation beyond 2 years for his plan. Next slide. This is a charting done on a patient that was referred to our office for 4 quadrants of root planing. She is actually a very interesting case, diagnosed with Ehlers-Danlos syndrome, which affects the connective tissues. Unfortunately, she had to have a pause in her dental care due to COVID and had severe inflammation on presentation. You will note that she has some 4mm pocketing posterior with lower anterior recession, mobility, and bleeding. So, is this in fact a case for root planing? Let's see the images. These are the radiographs that were sent from the referral. Again, I will have you look at the crest of bone in relationship to the CEJs. Bone here is pretty close to the enamel on these images. Although there are some areas of deeper measurement, this patient has altered passive eruption and inflammation subsequent to lack of dental care. We actually did not prescribe root planing, but instead a scaling in the presence of inflammation. The recession present will be treated with a gingival graft, which includes localized scaling and root planing when preparing this area for the graft. Next slide, please. So when it comes to periodontal maintenance, this can be an actual tough exercise, and there are frequent claim denials because some carriers will have limited benefits for D4910. Some carriers will only reimburse if delivered within 2 to 12 months of root planing. Some will deny benefits unless 2 or more quadrants have received prior therapy. There are no such limitations in the CDT Code definition for D4910. It is best to find out how your patient's plan covers this procedure before delivery to inform patients. If known, tell the patients in advance that plans provisions may not provide reimbursement for D4910 for extended periods of time, and that the patient may be responsible for the costs. I happen to see a question in the chat box, and I do want to touch on the 4910-1110 switch, as I like to refer it. Somewhere along the way, patients have convinced themselves that they only get D4910s in a periodontal practice. You are all probably going to get tired of being told, but it's very important that you code for what you do and do what you are coding for. So even if you are doing a 4910 in the office, you should code for that and explain to the patient this is what they need for health. If you are doing a prophy or a D1110, then you should code for such. In my opinion as a periodontist, periodontitis in its true form is a chronic issue. Well-designed maintenance programs should prevent the patient from needing more root planing, osseous surgery, or other in-depth treatments. In my own experience, I can probably count on one hand how many of my patients don't need a 4910 every time, regardless of whether we do it or our restorative colleagues do it. That being said, I know the position that patients can put us all in when they want their 2 free cleanings per year. Just make sure you are delivering the care that is appropriate to maintain the patient's periodontal health, regardless of coverage. I hope that answers the question in the text box. Now I'll turn it back over to Dennis.
That was great information, Jessica. Thank you so much. I'm sure that information will be very helpful for dental practices, And now Dr. Johnston will discuss ADA advocacy and available online resources to help dental practices with dental insurance questions. Mark?
Thanks, Dennis. Many of our listeners have heard what I'm about to say many times, but it is certainly worth repeating. I highly recommend you consult with your personal attorney before signing any contract. The American Dental Association also offers members an important resource for you, the ADA Contract Analysis Service. Members may submit an unsigned contract to their state or local dental society, who will forward it to the service. The service provides a plain language explanation of contract terms of each agreement analyzed. The service does not provide legal advice or recommend whether a contract should or should not be signed. Next slide, please. There are many reasons why a dental office may be unsure about which procedure code to use. One reason may include the infrequent delivery of the procedure. These ADA resources can help provide coding guidance. The CDT manual. It is recommended that providers read the complete entry, code nomenclature, and descriptor before deciding on which code to use. Along with the manual is the CDT companion guide. It will offer guidance. Examples include a relevant coding exercise, questions and answers, and in-depth clinical coding scenarios. The second source of procedure coding guidance can be directly obtained from the American Dental Association, both online and person-to-person. On your browser, please type in ada.org/CDT. This leads you to the CDT Code homepage that contains hyperlinks to additional related information. One of these links is titled Coding Education. And this is where several guidance documents are posted. These guides may be read or downloaded at no cost, or you can send an email to dentalcode@ada.org. Let me repeat that email address. dentalcode@ada.org. And don't forget, members can always call the ADA toll-free at 800-621-8099. This service is also available to non-members who have purchased a CDT manual and can call the number on the screen for one-on-one assistance. Next slide, please. Next, I would like to make sure all of our listeners are aware of a new work product put out by our council. The ADA has created two new documents, a long form and a short form, to help with scaling and route planning claim submissions. Simply type ada.org/dental insurance into your browser and select the Improve Claims Success box. From there, you will scroll down the page until you find the claims submission, scaling and route planning PDFs. Since the release of these two documents, our council has received many positive responses. Please take the time to print them out and go over the details with your dental team. Dennis, please continue.
Great. Thank you, Mark. Appreciate that. At this time, for assistance regarding dental insurance concerns, member dentists can call the ADA's toll-free telephone number, which Mark just gave you, or you can email us at dentalbenefits@ada.org. Dental insurance support and third-party payer concierge services are only provided to member dentists and their staff. And now we will try to take as many questions as we can in the remaining 15 minutes. And I'm going to keep our contact information on the screen for you so you can see the websites and you can see the mailboxes and the phone numbers for assistance. And let's see what we have to start with. All right, bear with me while I see. So it says here, how to bill 4910 when SRP completed in another office, how to bill when alternating with perio office. So I know Jessica touched on that too, but Stuart, I'd like to get your thought on that from the payer perspective.
Well, of course, and thank you for asking that question, because it's a common issue that we have, some misunderstanding and confusion on both in provider offices and in the industry. You know, it is kind of an interesting situation where in the code set, we have both therapeutic and preventive codes. You have root planning and scaling. There's one school of thought that says once a periodontal patient, always a periodontal patient, and you will always report the 4910 periodontal maintenance. However, that has to be asterisked or footnoted. If your treatment is so successful, your patient is so motivated, home care is so great, could you conceivably have a patient that has gone from a therapeutic phase back to a preventive phase? The D1110 prophylaxis is a preventive procedure. With proper documentation, periodontal charting, and history, you could probably prove that point. It could occur. The caution is submitting claims for a 4910 periodontal maintenance interchangeably with a D110 prophylaxis to maximize benefits, when in fact you are stating by your submission, I have a patient that is going back and forth between preventive and therapeutic, and then therapeutic and preventive. What are you trying to prevent if the patient's already in therapy? They kind of contradict each other. So although the codes are not mutually exclusive of each other in the code set, getting back, and I know we're all got this playing in the back of our head, report what you do what you report. You could conceivably have a patient who is going back and forth between offices. The fact is they're periodontal maintenance patients. And just because one office is doing one procedure and another office is doing another procedure, it would be inappropriate to just simply toggle back and forth between preventive and therapeutic codes when that's not what's actually occurring in that patient's presenting conditions.
Thank you, Stuart. The next question, can you charge for gingicane? Jessica, you want to address that one?
So we do not have a specific CDT code for gingicane. I know there are several codes that offices will make up in their software to help kind of internally track what they're doing. And whether or not you charge for that is a practice by practice basis. But in terms of there actually being a CDT code for that, no, there is not.
Thank you. Next question, can you debride and do a comprehensive oral examination on the same day? Who wants that one?
I can take that one. So prior to the CDT changes last year, no, you could not, because the way that 4355 was defined, it specifically stated that you could not complete an 0150, an 0160, or an 0180 at the same time. We changed that code, however, and now if you look at the definition of 4355, it does allow a restorative examination to be completed at the same time. However, I'm sure Dr. Balikoff will tell you that it's up to plan design whether or not it can be benefited. Stuart, did you have something to add?
Yes, thank you. That addresses it perfectly, but I would like to throw in a comment that I am going to share. I do talk to quite a lot of providers, and my staff talks to quite a lot of providers. And one of the issues we find causing abrasion in claim submission is the dental office not having a current CDT code book. And that's a great example of how the code has changed several times over the last 7 years. The definition has changed, and having a current CDT code book would guide you to that determination. So it's key to purchase that every year.
Thank you. Next question says, what does JP mean on the tooth system area?
I can throw in another plug. In the coding companion and the resources that the ADA provide, that could be addressed. That's a great question. The JP system is designed for the American Dental Association's universal tooth numbering system, 1 through 32 teeth for the permanent dentition and the A to T for our primary dentition. That's JP. You could also designate JO when using the International Standards Organization system, different tooth numbering system. The ADA claim form, my understanding, was to be able to let providers communicate and report the systems that they use as a reporting tool. But yeah, I hope that answered the question.
Thank you, Stuart. So this one I believe is intended for you also, because it says, why do you prefer PAs over bite wings? I try to send an FMX, but I believe the bone levels are best evaluated in a bite wing radiograph.
Let's talk about radiographs for a second. Great question. That gets back to plan design, that particular plan's clinical policies, guidelines, and claim submission guidelines. So clinically, I don't disagree. There are times when my periapical does not capture the orientation that I can capture in a bite wing. And of course, when I say capture, we of course are talking about my dental assistant who can run circles around me in radiographic imaging. When it comes to the submission, that gets back to the plan guidelines. Many times I will have providers, and I saw it on a comment on my slide, they'll send the entire FMX. Sending the entire radiographic survey will address it. A shameless plug for Dennis, you've heard him say on several webinars, if you send in everything, they cannot ask for anything. And that kind of goes to that philosophy. To be sure your claim is properly adjudicated, if you have a full mouth radiographic survey, that would be great to send that in. Then the reviewer, if it drops to review, has all the information in front of them to make the proper determination.
Thanks. So this question says, well, it's more of a comment, but I want to see if anybody wants to comment on the comment. So some payers want quadrants indicated for the 4342, and some want tooth numbers. If we submit with tooth numbers, they are often rejected. Any thoughts on that?
That gets back to the different plan requirements. When I submit claims in my practice, I provide both the quadrant and the tooth number. Again, all the information is there. They just pick and choose what they want. You've provided everything from your practice.
The next question here is, how come it is put upon the office to indicate the teeth numbers? Can adjusters not look at paro charting and see what teeth fit the pocket levels? I assume that one's for you, Stuart.
I would assume as well. In certain cases, yes. When we have a submission that comes in for a full quadrant, and radiographically there are only 3 teeth in that quadrant, the others have been extracted or missing, that's not a difficult call. When you have, as I showed in my example, claims where there are some teeth that are 3 millimeters and some teeth that are 4 millimeters and 5 millimeters and 6 millimeters, it's incumbent upon the office to record the proper tooth so that the payer can update what's called the patient tooth chart. If you have, for example, teeth 2, 3, and 4 on one submission, and then later on in the year, you're providing 43, 42, root scaling and planing with a partial quadrant, but only providing therapy on teeth 6, 7, and 8, you could run into a benefit conflict. We've already paid the full partial quadrant. Maybe there's an adjustment to be made, maybe not. So that's why the teeth number go with the claim. It updates the patient's tooth chart, which could also play into frequency and other plan limitations.
Thank you. Question for Mark. Mark, what advice would you give to a dental office when a patient comes in and needs scaling and root planing? What advice would you give them before they get the procedures done?
Thanks, Dennis. I was, falling asleep there, so thanks for throwing me a bone. Anyway, anytime you have a conversation with the patient, it's always a great opportunity for education, and health education is very important to everyone. So you have to have the time, take the time, show illustrations, and let them know that you don't know exactly how their benefits will handle this situation. All you can do is gather the information, send it in, and you'll find out an answer. Now, a predetermination does not mean a pre-authorization. And I know that they oftentimes use those terms interchangeably. Predetermination, the insurance company will give you an idea of the benefits that are available. Technically, the definition for pre-authorization means that the insurance company is going to hold those funds for that procedure to take place. So when you're talking with patients and with the providers, you're careful to not use those terms interchangeably. It comes down to communication, Dennis, and I think that if you take the time to explain to patients, to show them the radiographs, to show them an illustration on the probing depths and the calculated attachment loss, it helps in the long run. There are no surprises.
Great, thank you, Mark. Another question here. It says, it seems that insurance is more focused on bone loss from x-rays versus other indicators. How can a claim get paid without visible bone loss? Stuart?
I'm assuming that's for me.
Yes.
Right. So the appropriate documentation and diagnostics is both radiographic imaging and periodontal charting. Combining the two together, one or the other really doesn't tell the complete story. We know as clinicians, one of the most difficult tasks that we have to master is consistent periodontal probing. It can vary not only from clinician to clinician, it can vary from practitioner during the time of the day, whether you're fresh in the morning or tired in the afternoon. The angle of the probe, the pressure of the probe, it's a very difficult, demanding technique. So that kind of puts a little bit of a realistic spin on periodontal probing. When you combine it with the radiographs, that tells the story. Conversely, if the radiograph is angled or of a poor diagnostic quality, but has some diagnostic quality, then the periodontal probings back that up. So they work hand in glove, which is no different than what you would do to document any case medical legally.
Thank you. Jessica, can you give us the code again for scaling in the presence of gingival inflammation?
Sure, Dennis, that's 4346.
Thank you. And I think we've got time for one more question before we finish up, because we want to launch a poll when we get done here. And we also want to show you how you can get your CE credit. So, and Stuart, this might be for you too, but I'm not saying your company does this, but it says, why would local by injection be required when there are now topical anesthetics that give profound anesthesia effects?
Right. So there are some agents out there that do provide profound and some that claim they do and do not. We know that if you are truly planing the root, not just scaling, planing the root, that it can be very sensitive to the patient. Some plans, based on the review of their literature, their policy guidelines, will require intramucosal injections. Some, as I shared, will just say local anesthetic, and some are silent.
Okay. And I think we've got one more time for one more here too. It says, if a patient has always been a 4910 patient and had an SRP a while back and now changes insurance and they don't have a history with this insurance plan, what do you do? Any suggestions there?
That is, yes, I think that's for me. I'll assume it's for me.
Sure.
Yeah, and we see that all the time. members do transfer enrollment from plan to plan. And if you have the history, you would provide it in the narrative. And if you don't have the history, right, be honest, tell that in the narrative too, because not all the plans communicate with each other when they take over each other's clients. So that's where, hey, patient had root planing and scaling at Dr. Balakov's office at this date. That would be very helpful in the adjudication process.
Gotcha. All right. Well, thank you very much for that, Mark and Jessica and Stuart. And we just now launched the poll, so hopefully you are getting that right now. And we hope that you do take the time to complete the poll, because your feedback and your comments and your input will help us deliver high quality programs in the future. So I'm going to be silent for just a moment here while you complete the poll that was just launched. And we'll give you a minute to do that, and then we will show you how to get your CE.
Dennis, this is Mark. If you, while you're waiting for people to fill out their survey, could you give approximate date that this might be posted online? There's a lot of questions in the Q&A about people being able to share this in the future.
Oh, thanks, Mark. Yeah, depending on what kind of a backlog they have right now, it could be up, in less than a week, or it could be, as long as 2 weeks. But my guess would be it should probably be up in about 1 week from today or tomorrow. So, and we send out an email afterwards. So if it is posted before that email goes out, I will include a link in that email. If not, if you go to ada.org/dental insurance, one word, you will find the posted webinar right there. Thank you, Mark. Okay, so I'm going to show you how you get your CE now. It will take approximately 10 business days to receive your letter via email. If you have any questions about it, or you're wondering why it's taking so long, please email ce_online@ada.org. And as a reminder, an archived version of the webinar will be available. You will be sent an email directing you to the site. And finally, this does conclude our presentation for today. We thank you for joining us, and we hope you have an awesome day. Thank you for participating. Goodbye.